Now the name itself suggests, what do you mean by premature rupture of membrane? That means the rupture of amniotic sac, a rupture of amniotic membrane before, okay, the normal time. For example, the labor pain has not yet started, but there is leakage of amniotic fluid. This is known as premature rupture of membrane. So it can be just few hours prior to the delivery, or it may be more than 18 hours, or sometimes even more than 24 hours prior to the delivery. In those, two later cases, there is a lot of complication associated with PROM. So with this background information, let's enter into the topic. Now, all of you, please focus on this picture here first. See here, this is a baby. The baby is, surrounded by amniotic cavity and amniotic membrane. When this amniotic membrane gets ruptured, there is leakage of the amniotic fluid outside. It is known as premature rupture of membrane. And this should occur before the anticipated time. So rupture of the fetal membrane before the onset of labor, whether at term or preterm, is known as premature rupture of membrane. So in case of preterm delivery or labor, we add another P here, that is preterm premature rupture of membrane. Okay, preterm premature rupture of membrane, and just PROM for premature rupture of the membrane. It is also known as amniorexis. Amniorexis means discharge of the amniotic fluid. Prolonged rupture of membrane means more than 24 hours has elapsed between the rupture of membrane and onset of labor. Now, in the introductory, lines, I clearly told you this is a big problem, okay, for both baby as well as mother, because it has a high chance of ascending infection. And after the birth of that baby, we should do, okay, the sepsis workup right at the time of birth. If it is already more than 24-hour gap between the rupture of membrane and onset of labor. Now see there, preterm rupture of membrane means it has occurred prior to 37 weeks of gestation, and it is associated with preterm labor. You already know that now, okay? And rupture of membrane before 37 week and prior to the onset of labor is known as preterm premature rupture of the membrane. So these are the different definitions. Let's move on. Now, what are the risk factors, okay, of PROM? There are maternal risk factors and there are fetal risk factors. Now the maternal risk factors of PROM are ascending infection like cervicitis, vaginitis, sexually transmitted disease, or even UTI from the lower genital tract is the most common risk factor. Now it is both way actually. Infection is the commonest risk factor of PROM, and PROM, if it is of a longer duration, that is more than 18 to 24 hours, has high chance of causing fetal infection as well. Okay, so both things are correct here. Multiparity. What do you mean by multiparity?
More than one labor, more than one.
More than one
Exactly.
pregnancy.
More than one pregnancies.
Exactly.
But
You
after
can
the
say
viability.
exactly multiparity. Okay, multiparity means more than one pregnancy. Multiparity. The period of viability has to be crossed. Then only we call it parity. Always remember that. Cervical incompetence. The cervix is open. It is not tight enough, and it is a common cause of recurrent abortion, especially in the second trimester. Apart from that, it can also lead to premature rupture of the membrane. Family history of PROM is a risk factor. Low socioeconomic condition or status and poor nutrition is a risk factor. We really do not know what is the connection there. Probably it is not a direct connection, but it is associated with other problem. And other risk factors like a local membrane defect and cigarette smoking can also be listed here. These are the maternal one. Among the fetal, congenital anomaly of the fetus, multiple gestation means twin, triplets or quadruplets. These are called multiple gestation, and other risk factor which are associated with preterm labor, which we discussed in our last class. All of these can be listed here. Okay, but among them, the most important one is ascending infection from the lower genital tract, and it is going upward. This is the number one risk factor of premature rupture of membrane. Now, how we diagnose it? What are the clinical presentation? The most common or the most obvious clinical presentation is a sudden gush of copious vaginal fluid or continued leakage into the vagina. Okay, now see here, sudden gush of copious vaginal fluid or continued leakage. This vaginal fluid is amniotic fluid actually. On external examination, the clear fluid is flowing out of the vagina. Sometimes this clear fluid is mixed with a little bit of blood, but not throughout, A bit of blood may come in the beginning. That's it. After that, a clear fluid will come. And when we do ultrasound, most of the fluid has already gone out, right? So only a small amount of fluid is left, that is oligohydramnios. It is seen in ultrasound. Now see this, the ultrasound is the must, it is the must examination to rule out fetal anomaly, to assess the gestational age, and to assess the biophysical profile of the fetus. So ultrasound is always done before delivery if someone comes with premature rupture of the membrane. Now, I'm sure I've explained a little bit about biophysical profile also in some of my last classes, though we did not talk in detail. Just remember, biophysical profile means how well the fetus is inside the uterus. What is the heart rate of the baby? What are the other ultrasonographic parameter? This is known as biophysical profile. We'll talk about this in the upcoming classes as well. Okay, so let's move on. Now, regarding the diagnosis of premature rupture of membrane, it is diagnosed by sterile speculum examination meeting the following criteria. So we have got certain criteria here. So let's discuss those criteria. Pooling positive. What do we mean by that? When we do speculum examination, this is a vaginal speculum. This is used to examine, okay, especially the cervix and the fornix of the vagina. So we can see the collection of clear watery amniotic fluid in the posterior vaginal fornix. This is the deepest vaginal fornix. Now, vaginal fornix means, okay, I'm sure you still remember this. These are the folds, okay, of the mucosa which are going on the side of the cervix. They are going on the side of the cervix. In other words, the cervix is projected inside the vaginal canal. So the upper part of the vagina is having a bit of boundary around the cervix. This area is called fornix. So right now we are talking about posterior vaginal fornix. Okay. So if there is a collection of the fluid in posterior vaginal fornix, this is one of the criteria we need. The second one, nitrogen positive. Now, this nitrogen is a chemical substance. The fluid turns pH sensitive paper blue. The pH sensitive paper is inserted and the fluid should turn that pH sensitive paper into blue. This is called nitrogen positive test. And third is called Fern positive test. That means the fluid which is collected there should display a ferning pattern when allowed to air dry on a microscope glass slide. So what we do now, we collect some of the fluid, okay, put few of the drop on the microscope glass slide, allow it to dry. It will show a fern pattern, means leaf-like pattern there. So these three criteria are important one. regarding the diagnosis of PROM. Let's move on. Now see this, look at this picture. Okay, this is the ferning pattern of the amniotic fluid. If you look at very carefully, okay, if you look very carefully, you see a leaf-like pattern here. These are ferning or fern-like pattern. And this is seen when we allow the amniotic fluid to get dried up on a glass slide. Now let's talk about one of the related condition of PROM, and that is chorioamnionitis. Now let me remind you once again, after premature rupture of membrane, okay, any bacteria which are present on the vaginal canal can easily ascend up and go into the uterine cavity because the barrier of that amniotic membrane is ruptured or breached. If infection occur of the fetal membrane, this is known as chorioamnionitis. So chorioamnionitis, infection of chorion as well as amnion. So it is diagnosed clinically with all the following criteria needed. So let us underline this. One is maternal fever. Another is uterine tenderness. Third, presence of confirmed PROM. And fourth, there is no URTI or UTI present in the mother. What does that mean? That fever should not be caused by any other infection in the body. Other infections should be ruled out. Then only we pinpoint, yes, this is a cause of fever. So maternal fever, tenderness of the uterus, presence of confirmed premature rupture of membrane, and we have to rule out URTI or UTI. Then we think about chorioamnionitis is the disease there. How to manage, okay, this type of cases? If uterine contraction occur, tocolysis is contraindicated. Now, why tocolysis is contraindicated here? Anyone can explain to me why? What do you mean by tocolysis first?
So tocolysis is the prevention of
pregnancy.
it
Premature pregnancy,
is the prevention of premature birth, sir.
Okay,
labor.
good.
Stopping
why?
of premature birth, tocolysis.
Exactly. So why it is contraindicated in this case of premature rupture of membrane and chorioamnionitis? Why?
Sir, it is contraindicated because, sir, when rupture of membrane occurs, so we will go for the delivery. So if we stop the contraction, delivery will not occur, sir. Like this.
Very good. Yeah, I accept your answer. Very good. You know, in a very simple language. Yes, please.
Another factor is that, like said, tocolysis, sir, like sir, it will prolong that latency, sir. That latency of that we can start the pregnancy, sir, and sir will also affect directly the fetus, sir. Main case.
Okay. Now see there. So I already got the answer, and that is the correct one. He has very nicely told. After membranes are ruptured, you know, the more delay we do, more chance of infection there. Absolutely correct statement. Now, for example, why to do delay? The membrane have already ruptured. The amniotic fluid has already leaked outside. There is a high chance of ascending infection to the baby who is lying inside the uterus. And tocolysis is stopping the uterine contraction by giving certain medicine, that is stopping the progression of labor, and that is not the good thing to do at this condition. Okay, so if PROM has already occurred, if you are suspecting a bit of infection already, don't stop the progression of the labor. If chorioamnionitis is present, obtain cervical culture to find out which organism is responsible. Start broad spectrum IV antibiotics and initiate prompt delivery. Don't delay it. The more delay you do, the more chance of infection in that baby. So that's why quick delivery has to be done. Now, if no infection is present, okay, if chorioamnionitis is present, we know what to do now. But if no infection or no chorioamnionitis is present till now, management will be based on gestational age as follows. Just pay attention. It's very easy to understand. Before the period of viability, that is less than 24 week, okay, or less than 20 week, whatever period you want to take, fetus cannot survive. Okay. Fetus cannot survive, and before that period, we call it abortion. Okay, so if something happens, if the discontinuation of pregnancy is thought or induced or happened on its own, all these things are coming under, okay, abortion. After that, okay, we talk something else now. See here, with preterm viability, 24 to 35 weeks, conservative management is done because till now the infection has not occurred. Hospitalize the patient and keep the lady at bed rest. Administer intramuscular betamethasone to enhance the fetal lung maturity if less than 32 weeks. Definitely, because we want the lung maturity in that baby who is going to be born. If we do not do this type of management and quickly if the baby is born, the baby will suffer from hyaline membrane disease or respiratory distress syndrome of prematurity. Okay, this is a serious condition. Obtain cervical culture just to make sure which organism is responsible, and start a 7-day course of prophylactic ampicillin and erythromycin. But you are never sure when this lady is going to be delivered, okay? But it is good if she deliver after we complete betamethasone course. Now at term, okay, the baby is already matured, the lungs are already matured, okay? So term means after 37 completed weeks of gestation, but even if it is a 36 week, the lungs are already matured because they mature at 34 weeks of gestation. So we don't need to worry much. Initiate prompt delivery. Don't delay, because there is no point to delay now. If vaginal delivery is expected, use oxytocin or prostaglandins. And if vaginal delivery is not expected, perform cesarean delivery or cesarean section. So these are the management issues in case of term premature rupture of membrane. So what is the only difference between a preterm premature rupture of membrane management and term premature rupture of management? If there is no infection in preterm premature rupture of membrane, you can wait till you give that betamethasone course. That is the only difference between these two. Otherwise, we have to deliver the baby quickly there also, but we are afraid the lungs of that baby is not mature enough. The surfactant has not formed properly. So the baby will have a bit of complication. So we can take a bit of chance there in case of premature rupture of membrane in preterm delivery. Now, some further, management, points are: admit for expectant management and monitor the vitals every 4 hourly, daily biophysical profile of the fetus, and check the WBC count. These are easy things to do. Avoid introducing infection with repeated examination. Now, this is not very good thing to do. Why? The amniotic, membrane is already ruptured. That barrier is already gone. So do not try to examine, repeatedly. You may introduce the infection there. Okay. If the examination is necessary, I will go for speculum examination. Sterile speculum is inserted into the vagina, and I'll closely watch there rather than doing a bimanual examination. Bimanual examination means per vaginal examination. Okay, one hand is above the symphysis pubis, another hand or few of the fingers, to be precise, 2 fingers should be inserted into the vagina and examined. Now cultures are taken, okay, and these are the important organism. Just have a look here: gonococci and GBS. Now what is the full form of GBS?
Sir, the Guillain-Barré syndrome.
No, not here. You are right. If I ask a general question, you can answer like that, but not regarding this. This is the name of a bacteria. Which bacteria is this?
Group B streptococcus.
Sir, the Streptococcus agalacti.
Exactly. Group B Streptococci or Streptococcus agalactiae. Very nice. So GVS is Group B Streptococci. This is one of the common organisms which is present in the lower part of the vagina. So we have to culture lower vagina for Group B Streptococci and cervix for gonococci. And usually they are grown in the culture, okay, and we should treat them. Now, let's talk about fetal lung maturity a little bit. Though in the last class also I gave you a little bit of knowledge there, but this is a good question which may be asked in your exam. So let us repeat it again. So how to assess fetal lung maturity? How to do that? If the question is asked like this, your answer should be straightforward. That is done by lecithin sphingomyelin ratio of the amniotic fluid. So we need to, analyze this lecithin sphingomyelin ratio from the amniotic fluid, and this is the normal LS ratio between 2 to 2.5. Okay, if it is less than that, that means the fetal lung have not matured. Fetal lung have not matured. Okay, now let me write that term for you. Probably students are confused. What is the meaning of this L and S? This is lecithin, okay, and sphingomyelin. Yes, lecithin and sphingomyelin. So this is the ratio we are talking right now. So here, consider the administration of betamethasone, which is a corticosteroid, to accelerate the maturity if the fetus is less than 32 weeks gestation and if there are no evidence of infection. Infection has to be ruled out. If infection has already occurred, we don't do this type of management. As soon as possible, the delivery has to be done. Consider tocolysis for 48 hours to permit administration of steroid if preterm premature rupture of membrane induces the labor. But once again, there should not be any infection inside the uterus. Then only I can go for tocolytic therapy. And this is only done in preterm premature rupture of the membrane. If the baby is already more than 36 weeks of gestation, we don't do this type of therapy. We want to deliver that baby as soon as possible. Another point, if not in labor or labor not indicated, consider antibiotics. Now, this is controversial. Now, why it is controversial? Let me explain. The premature rupture of membrane can be of different durations. Sometimes it may be just 2 hours prior to the onset of labor. Sometimes it may be 10 hours prior to the onset of labor. Sometimes it may be 18 hours. Sometimes it may be more than 24 hours. If it is less than 18 hours, okay, you usually don't give antibiotics coverage. But if it is more than 18 to 24 hours, you definitely give. That's why it is written as a controversial there. We don't generalize the things here. We decide according to the pregnancy. Now, studies show broad spectrum coverage increase the time to onset of labor from PROM by 5 to 7 days with no increase in maternal or neonatal morbidity or mortality. Very important point there. Let me explain it once again. There are different studies done all over the world, and they show broad spectrum antibiotic coverage increases the time to onset of labor from PROM by 5 to 7 days without any excessive increase in maternal or neonatal morbidity or mortality. But once again, let me clarify the point here. If chorioamnionitis has already occurred, we don't go for this type of management. But if there is more than 18 hour or more than 24-hour premature rupture of membrane and till now there are no evidence of chorioamnionitis, then this type of management can be done. This is the meaning. Deliver urgently if evidence of fetal distress. There's no doubt at all. If fetal distress occurs at any time or any gestational period, you deliver the baby quickly, either by vacuum, forceps, or cesarean section. Or if there is chorioamnionitis, you never wait. You deliver the baby urgently in any gestational period. Okay, so these are some of the important management issues. Now, to repeat whatever we have studied till now, all of you please focus on this table once again. Now, this is the degree of prematurity, okay, and this is the management which we do. If the baby or the fetus is less than 24 weeks, means before the period of viability, we say terminate the pregnancy. Okay, consider abortion for this. You already know. From 24 to 25 week, individual consideration with counseling of the parents regarding the risk to the preterm infant. This baby, even if delivered, almost doesn't have any chance to survive. The baby is going to die, high chance of death. So we talk nicely to the parents what to do, and whatever they want, you have to respect their decision. Let me repeat this again. We have to respect their decision. You give different option to them, and the decision should be done by them. You don't decide from their side. This is not called counseling. For example, you say, what are the risks to the baby? There's high chance of death. You say that directly. Still, if you want to go for delivery, I can do that in my hospital, but I cannot guarantee what is the prognosis of this baby. Then they will decide. If they say, no doctor, we want to terminate it right now, we don't want to continue, it is their decision. 26 to 34 week expectant management, as prematurity complications are significant. And what do you mean by this expectant management now? You give betamethasone therapy, you give tocolytic therapy, okay, and try to push the delivery as later as possible. Just allow time for that fetal lung to get matured. From 34 to 36 week is called a gray zone, okay, gray zone, because the risk of death from respiratory distress syndrome and neonatal sepsis is the same here. Okay, so if possible, you push it further. If not possible, you can give birth and then take care of the baby. More than 37 week, okay, induction of labor is done, since the risk of death from sepsis is greater than respiratory distress syndrome. So you don't delay now. You quickly deliver the baby as soon as possible. Now we are coming toward the end of this important topic, very short topic but really important one. What are the hazards associated with PROM? Why PROM is considered one of the complications of pregnancy? See here, if fetus remains inside the uterus, these are the neonatal conditions which can develop: infection and sepsis, deformation, umbilical cord compression, and pulmonary hypoplasia. Now some explanation has to be given here, okay? So please pay attention. Infection and sepsis, every student can understand why the chance is high, because the barrier is gone. The infection can easily ascend up and can lead to the infection. Easy. Deformation means it is a compression of the fetus by the uterus. Now, what is happening to the amniotic fluid after the membranes are ruptured? It leaks outside, right? So the protection given by that amniotic fluid is gone now. There is no barrier between the uterine wall and the baby. So as a result of that, okay, the uterus constantly keep on compressing the baby. So different type of deformity may develop. That's how you should understand here. Umbilical cord compression can occur in the same way, because umbilical cord is nicely floating on that amniotic fluid, but that is gone now because the drainage of amniotic fluid quite quickly. So Umbilical cord can be compressed by the presenting part. Why pulmonary hypoplasia occurs in premature rupture of membrane? Who can answer this? Anyone?
Sir, because the amniotic fluid leak outside and the baby swallow the amniotic fluid, sir. It will help in the maturation of the lung. So if amniotic fluid is out, so it will not swallow, sir. That's why.
Very good. Good answer. Good. Excellent answer. Okay. I'm sure many other students also remember this because we have talked about this before. Remember, for the development of the lung, we need amniotic fluid. If amniotic fluid volume is less, okay, that amniotic fluid cannot stretch the lung, results in hypoplasia of the lung. This is known as pulmonary hypoplasia. And if this baby is delivered, the baby will suffer from respiratory distress. So this is the mechanism. Now, what are the maternal conditions? These are the hazards associated with PROM: chorioamnionitis and sepsis. No need of any discussion. Deep vein thrombosis. Okay, deep vein thrombosis. It is a general, problem of pregnancy. On top of that, if that lady becomes sick, or if the lady develops sepsis, the chance of thrombosis is even higher. And psychosocial separation because of the infection, because of the illness, these are some of the problems. If preterm delivery occurs, the neonate will have a lot of complication now. Now, why this preterm delivery occurring? Because of PROM. And after the preterm delivery, these are the problems in the neonate. Respiratory distress syndrome is the most common one. Of course, if the baby is delivered prior to 34 weeks of gestation. PDA, patent ductus arteriosus, is one of the important problem of preterm babies. Now, PDA occurs between which two blood vessels? PDA.
Sir, between the aorta and the pulmonary artery.
Aorta and pulmonary artery.
Exactly. Between aorta and pulmonary artery. Okay. It is a normal structure inside the uterus before the baby is born. But after the baby is born, it should disappear. It should get obstructed. Okay. But if it is still remaining like that, we call it PDA, patent ductus arteriosus. And after the birth, yes, sure. Yes, what happened? Yes. Okay, so this is PDA. So listen here. Now, before the delivery, the direction of blood is from aorta to the pulmonary trunk. Am I correct? Before the delivery, where is the direction of blood flow in PDA? Yes.
Sir, there will be reverse shunting. Sir, reverse shunting.
Okay. Anybody else?
Sir, from the pulmonary artery to the aorta, sir.
Due to pressure difference, sir.
Good. You're absolutely correct. So before the birth, the blood flow in PDA is from pulmonary artery to the aorta because of the pressure difference. But after the baby is delivered or after the baby is born, pressure is much higher in the aorta. So the blood flow direction changes. It starts from aorta and goes to the pulmonary artery. So this much information is enough now because it's a big topic in itself. Intraventricular hemorrhage can occur in preterm baby very easily. Necrotizing enterocolitis is one of the complications of preterm babies. This is infection of the intestine. Retinopathy of prematurity, problem in the retina. Bronchopulmonary dysplasia is a problem of the airway, especially if the baby is kept under mechanical ventilator for a long time. And cerebral palsy is a problem of the developing brain. All these are associated with preterm delivery, and preterm delivery is caused by premature rupture of membrane in this case. Now, what is the prognosis of this condition? Premature rupture of membrane. So we are coming towards the end of this important discussion. It varies with the gestational age. Definitely, gestational age means whether the baby is, in the preterm group or term group. It depends on that. 90% of the women with premature rupture of membrane at 28 to 34 weeks gestation go into spontaneous labor within 1 week. So they go spontaneous labor within 1 week after a premature rupture of membrane. But they should not wait for 1 week at home. They should never wait. They should quickly report it to the center. 50% of the women with PROM at less than 26 week gestational age go into spontaneous labor within 1 week. And the complications of this premature rupture of membrane, though we have already talked about in detail, the common ones are listed here once again, is cord prolapse, intrauterine infection like chorioamnionitis, premature delivery, and contracture of the limb. This is called deformation because of the constant pressure, okay, by the contracting uterus on the baby. Different type of deformities or deformation may develop in the baby. Let me talk a little bit about cord prolapse. The cord, okay, can be compressed by the presenting part. That is one problem. Another one, if there is a bit of gap between the presenting part and the side of the cervix, that means if the head is not yet engaged, then the cord can easily prolapse downwards. And this is known as cord prolapse. A baby may die if this is, not noted in time. So these are some of the important prognostic point regarding PROM.